Good morning. Welcome to today's webinar on empowering conversations, how to get the information you need to live well and plan for the future. A special welcome to our guest speakers today, Dr. Ranjana Srivastava and Ms. Eleanor Davis. In the spirit of reconciliation with First Nations people of Australia, the Leukemia Foundation acknowledges the traditional owners of the countries on which we operate. We acknowledge and respect First Nations peoples' spiritual beliefs, connections to land, sea, and communities. The Leukemia Foundation pays our respect to elders past, present, and emerging, and extend that respect to all traditional owners across the nation. So September marks Blood Cancer Awareness Month. Despite advancements in care, there remains a troubling and stubborn health divide affecting many different communities across the country. We know that those that live regionally, First Nations people, culturally and linguistically diverse communities, and LGBTQIA+ communities are among those facing significant barriers to getting diagnosed quickly or receiving the best available treatment and support. These communities are at an unfair disadvantage simply because of where they call home, the language they speak, or the culture that they belong to. It's an unlevel playing field, which means we're still losing too many lives to blood cancer. Everyone with blood cancer deserves a fair go when it comes to getting diagnosed quickly and receiving the best possible treatment and care. It's time to end this lottery and close the cancer health divide for good. This spring, the Leukemia Foundation is raising awareness of the challenges facing many people in our community and taking action together to help close that gap. This includes increasing awareness of blood cancer among healthcare professionals in regional Australia, developing new resources for priority population groups, and raising funds to spearhead new initiatives and research. For more information on how the Leukemia Foundation are driving this, please go to www.bloodcancer.org.au. So before we start, a few housekeeping matters. For those who would like to ask questions or make comments, you can do so in the chat. This webinar is being recorded, so you will be able to access it after today. For those that registered, you will receive an email of the recording, and for others, you can access it via our website and our YouTube channel. Questions will be attended to throughout the webinar, along with we will also have a dedicated Q&A session at the end. We will do our best to try and attend to all the questions, but obviously we're restricted with time, and also to questions that are highly personalised may be really tricky to address specifically. So today we're talking about empowering conversations, how to get the information you need to live well and to plan for your future. We will be exploring how to have those conversations, those really important conversations with your doctor and your treatment team about what a blood cancer diagnosis means for you and your life and your future. Knowledge is power that guides discussions and decisions about your treatment and how this affects those around you. So I'd like to start by introducing our first guest speaker, Ms. Eleanor Davis. Eleanor is a Victorian lawyer who practices in the area of wills and estate planning, as well as deceased estate litigation. She works for her family-owned law firm, David Davis and Associates. Eleanor is the co-founder of LawLink and a software company creating AI programs for law firms. Eleanor is a key writer and presenter, having delivered papers in the area of estate planning. Before completing her law degree, Eleanor completed her Bachelor of Arts with a major in psychology and performing arts at Monash Uni. While no longer performing on stage, she still enjoys theatre, travelling, hiking, and time with her family. Eleanor will be sharing her insights from both her professional and her personal life about the importance of planning for the future. Thanks, Eleanor. Over to you.
Thank you so much, Linda. I will be sharing today, I think, empowering conversations that we've had actually within our family group. So recently my father was diagnosed with leukemia, and what I wanted to focus on was how we had some of those difficult conversations actually within our family. So I know that the topic today is empowering conversations. And to begin with, we found these conversations to be really hard and difficult and even at times gut-wrenching. But with each conversation of this nature, there is a feeling of empowerment slowly growing as we improve on our discussions and get closer to understanding as a family and of ourselves who we want to be, how we want to be with that person, and how we want to be together in all of this. So my family are particularly primed in their professional lives to deal with serious illness and death and to have hard conversations with others. My mother is a psychologist and for many years worked in an oncology ward at Ballura Private Hospital, and part of her role was to assist those in palliative care and their families to prepare for living with serious illness and death. And when I was a teenager, I would often go to the hospital and I would walk around the ward to try to find my mum. I would be able to pinpoint her location because all the laughter and fun that could be heard from a patient's room. I always thought it was beautiful how much joy my mum seemed to bring to those rooms in such sad circumstances, and how well loved she was by those families. My father is a lawyer who practices in the area of wills and estates, and he has spent a number of years in nursing homes or hospitals at a client's bedside with empathy and patience, taking instructions or witnessing and signing a client's wills. And once I turned 18 years of age, he was very excited because now he had an extra family member to use as a witness. And my mum rejoiced because she no longer thought she had the job. My father has an infinite capacity to listen and sit with kindness, empathy, and a sprinkle of humour with clients and their families, discussing their deaths and arranging their estate planning to ensure their loved ones were looked after once they're gone. And like my father, I have also been a wills and estates lawyer for 12 years and having difficult conversations with my clients on a daily basis. So when Dad was diagnosed with leukemia, I felt that my family would be well primed to having difficult conversations about living with a serious illness and death and dying. And in reality, I think that was only half true. I've learned that there is a real difference between our professional selves and how we apply those skills in our lives in an emotional circumstance. I think that in a strange way, both the deep love that you have for another person and the terror of their death seems to almost completely wipe out your whole entire skill set. That's not to say that hard conversations our family have had with each other have been bad or wrong, but they are imperfect. We as humans are imperfect, and we each need sometimes to do things in our own way in order to make sense of what is happening to us and the people that we love. I remember in the early days when we didn't have a proper diagnosis, but we were aware that my father did have some form of leukemia, and he spent a number of days in hospital at that time. My parents live 100 steps from my home. So naturally, while Dad was in hospital and knowing Mum would be alone, I asked her to come and have dinner at my house. And to my surprise, she said no, which was really strange to me. I asked her the next night, and again she said no. And I asked her the next night, and again she said no. I was concerned at this point because either my cooking was really bad or there was something kind of wrong, something strange was happening. Eventually, on the fourth night, she called me and invited herself to dinner. And when she arrived, she told me that she was practicing being lonely. She wanted to really feel what it was like to be alone in that house without Dad. She wanted to know how she would be okay to be lonely, because if she was okay being lonely, it was the only way she was going to get through. We started having some difficult conversations early on, and sometimes afterwards we would just carry on going to work as if nothing had been said and nothing had happened. And other times it would feel like there had been a real big shift within ourselves. And sometimes the person in the family you try to speak to is not ready to speak to you. which means you're then caught between waiting for that person to be ready or potentially pushing that person to face a reality that they're not ready to face. And sometimes that person who's not ready was me. The hard conversation is really an ongoing conversation that doesn't seem to have an end. It's something you pick up at various points and put down again, or sometimes you pick it up when new information comes to hand from doctors and medical professionals. But to start with, we asked things like this to my dad. If money or treatment wasn't an issue and you knew you were going to only live 10 more years, what would you want your life to look like? And then we'd ask if that answer changed if you only had 5 years or if you only had 2 years. And his answers to me seemed really boring. He wants to work. He wanted to spend time with his family, his wife, children, grandchildren, and friends, and he wanted a few holidays. I'd always imagined I would personally have a very extravagant answer to that question, a thrilling bucket list to complete that meant visiting exotic locations full of strange experiences. But in light of his diagnosis, when I truly considered the question, I think I'd really want the same. So you have to look at the answers he's provided, and then you have to layer in the realities of our world, such as finance, taxes, treatment, family obligations, other obligations you might have to make that work. And this conversation has developed over the last year from time to time as we check in with Dad to see if things have changed. Because as the reality of the disease sets in, what you want your life to look like might change. Different wants and needs become more or less important. While the core values of what he originally wanted are still there, there are differences. A subtle letting go of different aspects that may not be as important anymore and a refining of your life. Another really important question that I found to be personally empowering is that I've realized it's not just about what my dad wants. It's what my mum, my sister, and myself want for my dad. What we want for him is in some ways equally important because we need to ask ourselves what we want our lives to look like with him. And whenever we have these conversations, there are always tears, sometimes laughter, and a lot of getting off topic and talking about completely different things. And when that conversation is paused, because it's never really over, you are often left feeling empowered, that you have agency in your life, and that things can be faced and lived together. And that's just a little bit of our story about having some really difficult conversations with Dad over this time and working out how we want to be with him. So thank you for having me share that with everyone today.
Wonderful. Thanks so much, Eleanor.
No worries.
Your description of I guess the intersection of the professional and the personal, and how you illustrate that no matter how proficient we are at these conversations in our professional life, the relationship and the emotional connection to that person is often the overriding element, isn't it? And it can really change the way we have to have those conversations. So thank you so much for
my pleasure.
Just shining a light on that and how brave you've been in having those conversations.
Thanks, Linda.
On to our next guest speaker, Dr. Ranjana Srivastava. So Dr. Srivastava OAM is an internationally renowned oncologist, Fulbright scholar and award-winning writer. She is the recipient of the Medal of the Order of Australia for her contribution to the field of doctor-patient communication. In 2020, Ranjana received the John F. Kennedy Merit Award and a second prestigious Fulbright Award to obtain a master's in public administration at Harvard University's Kennedy School of Government. Educated in India, the UK, the US, and Australia, Ranjana graduated from Monash University with first-class honours and several awards in medicine. She has since worked in Victoria's public hospital system and specialises in the care of elderly patients with cancer. She has a keen interest in serving patients from culturally and linguistically diverse communities who are often disadvantaged and vulnerable. Ranjana's writing has been published worldwide. She's a regular writer for many highly regarded medical journals, newspapers, and has published many books in patient-doctor communication, life and death, truth-telling, and living well with cancer. She's a well-known and respected educator in the community and within the media on health matters, ethics, and patient-doctor communication. We couldn't really get a more perfect person here to have this conversation. I'll hand over to Jen to start the conversation. Thank you.
Thank you so much. What a beautiful setup, Eleanor. And I think that idea that things can be faced and lived together just really sets the tone for this conversation. And Ranjana, I know you've said oncologists specialise in the diagnosis and management of cancer. And, you know, you possess a lot of detailed knowledge about treatments and their merits and side effects. And you've spent a career applying this to different people from all different parts of the world. And today we really want to focus on your real passion for patient-doctor communication. And we know that good communication matters, but can you explain a little about why it's so important in this field of cancer?
Thank you, Jenny, and thanks everyone for joining us. And can I start by saying I was so moved to hear about your story, Eleanor, and your dad's story. And I think it really brings home that these difficult conversations and communication really happens within the tapestry of daily life. You have these conversations, you go home, you go to work, and so on. So I think it's a really important topic to discuss, and I'm so grateful to be here. So thank you. Why is communication important? Well, I think intrinsically, when you ask yourself that, you go, but of course it's important. I think from a medical perspective, doctor-patient communication, and which underlying that is good communication with your loved ones and good communication with yourself, I suppose, figuring out what you want is important because it really helps us plot the direction of care, which is different for different people. Your goals, your aspirations, your health, your other illnesses, your desires are different. And I think, we would make a mistake as doctors to treat every person the same, because really behind every illness there is a person, behind every patient there is a person. And so I think the importance of good communication is in bringing out that person so that medicine can serve that individual in the best way.
I like that idea too, that behind every diagnosis is a person and they have their own story, and it speaks to the idea that communication needs to be individualized. And I think we've had a lot of queries around how people get the best out of their appointments with their doctors. Because often you'll hear, and you would have heard this in your practice, people come away and say, I don't know what they said, or I've still got questions I want to ask that I didn't ask. And they feel like perhaps they've left appointments and missed an opportunity. So do you have any strategies for people to use to make the best of those moments, because they are fleeting, with their medical team and with their doctor?
I think that's a great question. And I'm going to try to keep my answers short because I know we'll have many questions. So I'm a big believer in lists. Appointments with doctors are short. They're not easy to come by. And so the first thing is, think about the things that you need to discuss at the doctor's, because you may not get a chance. The doctors often have their own agenda to discuss, often their own things to discuss. So carry a list, make sure it's there, it's visible, so that the doctor knows that you have come in with a list of questions. I think it's also very important with any sort of long-term illness, as far as possible, to bring another set of ears. Lots of people like attending appointments alone because they feel that they don't want to burden their family. From everything that I see of chronic illnesses, it's really important because it's important for the other person to hear what's going on. Sometimes you may be distracted, you may be feeling unwell. It's also just good for someone else to supplement the information that you may be providing your doctors, because it's something may have slipped your attention, or and often I see with my patients, they try to be more optimistic about their day-to-day living than they are. So they'll say, oh, tired, I'm not so tired. And then the person with them says, but hang on, you've spent most of last week in bed. So it's really important to hear truthfully what a person is like. So carry a list, make sure that the list is something the doctor can see, so you don't just carry a list and carry it out without having those questions answered. And I think it's about having some agency and saying you deserve to have those questions answered, as many of them as possible.
Thanks. I think we'll stick with just the broad themes around communication just to start with, but I know, what doctors say and what people hear are often poles apart, and both parties can come away feeling let down or disappointed, or that true connection wasn't really made, and for a whole lot of reasons. And I wonder if you have ideas about what's reasonable to expect from a doctor, and also from a wider treating team, that we can't expect doctors to have all of the answers. So how do we make best use of our whole team?
So I'm willing to confess my most humbling moments when I think I've done a good job. I've spoken to a patient for 20 minutes, 30 minutes. Patient walks out, calls the nurse immediately and said, what did she say? It's always a little bit humbling when that happens, to go, how did I miss all of that? So your question was, how do people get on the same page?
Yeah.
So I think one thing that I have started doing is, especially when I sense that there may be a communication gap, is to say to patients if they could explain some of what I have said. And it can be done in a polite way. It's not a challenging way to say, I'm testing your memory, and I did this week, to say to a patient who I felt was cognitively impaired. And I said, just to check your understanding, could you tell me a little bit of what we have spoken about? And unfortunately, she had very little idea, and she spoke about something else completely. Now, that was a really important aspect of information for me, as well as the family that was with her. From a patient perspective, I think it's good and important to sometimes pause the conversation and say something as direct as, let me make sure I understood you. And I think it works both ways. So paying attention, asking doctors to stop and to pause, because medical information is overwhelming. It's very scientific. And to not hesitate. I think a lot of patients I see are so polite and respectful that they nod along to whatever a doctor is saying. And then they go, I don't think I understood that, which is completely legitimate. It happens to all of us. And so to be able to have the agency to say, can you please speak slowly? Can I get some written information? If English isn't your first language, there are increasingly other language information that people can print out for you. I am always delighted when a non-English speaking patient comes in and says, I want an interpreter. Because a lot of people would just not do that. And, it's a bit of a heart sink moment, because then it'll be 10 minutes before an interpreter comes. I'm kidding. But I am delighted that a patient feels that they have the agency to say, stop, I'm not speaking without an interpreter. So I think there are things to remember. And again, I go back to bringing somebody else with you, preferably the same person, same couple of people who provide a thread of continuity. But I think, patients are not there to be talked at. They are there to be spoken to.
Thank you. I think that message received isn't always the one that's sent, also applies in a broader context. So I'm curious to know, from a professional perspective, how you help bridge that gap. Perhaps you've talked about team and patient, but perhaps between patient and family, and even different members of the same family. And I think Eleanor alluded to that in her talk about the difficulty of the conversations. Not everyone's on the same page at the same time. So what are some ways we can help family navigate that and navigate that with their health professionals?
A few weeks ago, I lost a patient who had been my patient for several years. And she always came alone to her appointments, and she was an educated, professional, English-speaking woman. She was lovely to look after. And it wasn't until she died that it emerged from her family that they did not know the full story of her illness. And it was a very tragic situation because I think there were a lot of missed opportunities as a result for me to communicate with them, for them to communicate with each other. And while I think she was trying to shield the family with the best of intentions, I think there's quite a lot of damage that can be done unintentionally. And my message would be to try to avoid that, because now that thing that didn't happen, we cannot recoup it. Those conversations, those moments about, as Eleanor said, what's important to you, what's important to us together.
Yeah.
So
Yeah.
I think one thing I have taken away from this as a doctor is to constantly ask my patients how much the family knows, what the family knows, and to try to offer that I am willing to speak to the family. And so if you're a patient and you find that it's difficult for you to explain all of this to your family, ask the doctor and bring your family in. You know, there are lots of nurses, lots of support people. It doesn't have to be a doctor-centric thing. So I think that's really important.
Yeah.
For patients, I think also to take some responsibility for keeping the people who are important to you involved in periodically. Some people have a spokesperson. If they have a large family, you don't want to tell everyone. So you have a spokesperson. It depends on what, everyone is different, isn't it, in terms of the stage of their illness, what they want to disclose. But it's helpful to have people in that journey.
It is. I will come back to those missed opportunities in a moment, but I think there's also, just in terms of talking about direct communication with your team, there's been an expression that sometimes people don't know what they don't know. So you can go into the appointment and the doctor, with all of the best will in the world, can say, what would you like to know? Have you got any questions? But if people don't know what they don't know and they don't know where to start, how can you help people have that conversation to get the information they need? Or what could we even do to give people more information, to be better informed before they go into their doctor's appointment?
This dovetails very nicely with Craig's question here. Craig said that he is a scientist. He is he is needing to undergo a stem cell transplant. And Craig's question is very legitimate, saying, given his high level of understanding, he doesn't understand why doctors are unable to provide the level of detail that he needs.
Yeah.
I'm very sympathetic to that, and I would be similarly inclined to want to know the things that I can understand at my level. So look, I think, I think it's useful for patients to indicate their level of scientific sophistication and medical sophistication and learning. And, the caveat to that is, just because someone is educated highly in another profession means that they understand medicine, and that's not to diminish anyone's intelligence. But I think it's very important to flag that you are someone who understands, whether it's the statistics, whether it's the survival, whether the nitty-gritty of toxicities. And I think that if you are asking for that information, it is our job to provide it to you. This week, I also met a patient who said that she is a refugee who cannot read or write in any language. That's equally important for me to know, because giving her pages of writing and statistics is not going to be the best way of looking after her. So I think you need to take stock of how much information you need, and feel free to ask that information. And if there's a continual habit of not being able to be provided that information, I think I would flag that with the treating doctor very clearly to say, I have now requested this information so many times. Can you help me understand why I can't receive this? I think the internet is a great thing, and there are lots of sources of credible information on the internet. So one way also for people like Craig is to discover and ask nurses and other support teams what are credible sources of information for a stem cell transplant, and then do some reading and take in some questions.
I think there's another, thank you, part of Craig's question, which is doctors being perhaps a little reluctant to talk about the risks and the potential for death in particular. And I guess that leads to a really good question that comes in about how does an individual contemplate that balance between quality of life versus length of life when they're making those care decisions, and what's involved in having that conversation with that doctor so that you're really genuinely feeling you are making an informed decision?
My personal philosophy as an oncologist is that the higher the risk of death, the more clearly I need to state that to the patient. It's after all their life and their death. And I think that's really important. In terms of how does one make that balance, so perhaps somebody can put in the chat. So I write for the Guardian newspaper, and I write a fortnightly column, which is not behind a paywall. And one of the columns I wrote was about this issue of time toxicity. So time toxicity is the time you spend, so whatever life you have, and the time you spend going to your consultations, going to tests, waiting for scans, waiting for results, traveling to the hospital, waiting in the waiting room, and so on. And for everybody, that time toxicity is going to be different, and you need to have a sense of, so for instance, if somebody is towards the end of life or in a palliative phase of treatment, they have had multiple treatments, they're not responding, the doctors are not particularly hopeful, but say, well, there is also this treatment you can have. I think that's a conversation about time toxicity. Is the time gained from treatment worth the time spent on treatment, on travels? How can I best spend that time? And I think that's a really important concept that we are slowly beginning to think about. And the reason I wrote about this in The Guardian is because I think this is how patients need to be empowered so they can ask whether this is worth their time, not somebody else's time, but their time. I think one of the things I've been meaning I will put up front, because it'll be an underlying theme, is people need to realize that not a lot of time in medicine is spent in medical education, is spent thinking about not providing active care, but providing supportive care, palliative care.
Yeah.
A lot of medicine is around cure, treatment, pushing the boundaries, which is fantastic. And it's great for a lot of people. And, you know, we all stand on the shoulders of great research and evidence, which means that people are living longer through conditions that they were not living as long with. Even in my career, sort of people who used to die from cancers like prostate cancer and melanoma are living longer, healthier lives. So I'm all for that. But I think medical education very much focuses on cure. And sometimes when you have a chronic illness, when you have a terminal illness, that's not what the patient is necessarily thinking about, but you need to be on the same page about communicating those things. So I think thinking about time toxicity, and I'd encourage you to read that piece, is really important, and that's going to be different. If you are somebody who is very young, who has young children, for instance, and I see those patients, they have a different bent of mind and different priorities. But in my geriatric oncology clinic, where I see a 91-year-old patient, they're like, I just want quality of life. I don't want to travel and wait and see you and have treatment that will be toxic. I'm content. So different conversations for different people.
Thank you. And I think it leads beautifully to a comment that we received from a gentleman that said, how can we be honest and question what we are told without being considered non-compliant? I feel like my doctor really doesn't understand where I'm coming from when I question the evidence for protocols for treatment and when I say I don't want to continue. How can I make him understand my perspective and build a way forward rather than feel like I've buggered up his treatment plan. And it really goes to what you're speaking about.
I'm very sorry to hear it, firstly, because I think, it pains me to think that a patient sitting across from me is having treatment to please me and not to make themselves better. And really, that shouldn't be the case. So a couple of things. I think if you feel that some people feel that they may come across as questioning or arrogant, as in patients feel, because they're questioning the doctor. So I think you can preface your statement. That's the simplest thing, to say, look, I know you know more than me, but I want to ask these questions about treatment. And hopefully, that's a way of breaking the ice. And if somebody is feeling particularly disrespected or, questioned, challenged, etc. So that's one thing, just simply saying it. I think the second thing is to name that emotion, to say sometimes, I feel like, I wish that I could have a better conversation about my goals. I think that really goes to the heart of, and so to be a little bit vulnerable, because I can assure you that most doctors, when they're seeing patients, are still thinking about the research, the evidence, the next clinical trial. That's the way we are trained.
Yeah.
Nurses can be your very good ally in this. The number of times a nurse comes up to me and says, by the way, Ranjana, I think, Mary really wants to talk about stopping treatment today. So that primes you, because it may not have been on your mind that Mary is thinking about stopping treatment. And lastly, I think if you've tried all those things and you still feel that the doctor is not listening, I'm a very big advocate of seeing somebody else and getting some opinions about who that person might be, who may listen to you, and everything from foundations and supportive care nurses to other places, to your GP, who is a person who is well known to listen to patients' views.
I think that's a great tip, and that idea that you can use other members of the team to support that collaborative decision making, that you can go outside the immediate auspices of the doctor, but you also have the opportunity to seek a second opinion, which is often very difficult for patients. They feel they're being somehow disloyal to that doctor, or in a way being disrespectful. And you talked earlier about being polite, and I think that still can be a barrier in terms of how people manage that communication with people. You've sort of talked about having those discussions when perhaps the doctor and the patient aren't on the same page. And I guess it raises for me the thought that, and Eleanor alluded to this too, you need to have ongoing discussions and different discussions at different points in your diagnosis and along that lifespan of or the trajectory of that disease. And I wondered how you would approach or suggest people approach different conversations at different stages. So whether they might be in watch and wait, whether they're in a position where they're more likely to have a recurrence, or in fact, if they've got advanced disease and they need to be having a different kind of discussion that might involve stopping treatment. What's that communication trajectory and decision-making trajectory that, as you see it?
So here is a tip. So as a doctor, I identify those conversation points at points where I need to switch treatment, because there's a reason for switching treatment, right? So if I'm switching treatment, unless it's for a side effect and I'm switching to something, usually treatments are switched because a person is progressing, not doing well in some way. So in my mind, those are junctures at which I need to reset expectations and I need to revisit the big picture. So it should be no different, I think, for a patient to say, well, now that I'm going on to a different kind of treatment, what can I expect? What is my prognosis if you are so inclined? What will the toxicities be like? Again, this issue of time toxicity. So at every stage, trying to weigh that, but those would be some concrete places at which you can have this discussion. I think the other one is when there is a dip in the way you are feeling. So we call that in medicine performance status, which is basically a big word to mean how are you doing on a day-to-day basis? Are you still going to the bank and to the groceries? Are you attending church? Are you going to social events, or are you spending more time resting on the couch, in the bed? So you can be on the same treatment, but you are not doing as well for whatever reason. So those are another moments to say, well, hang on, let's pause and have a discussion about where to from here.
Yeah, I notice Kathleen's just put in the chat, do you have any insights regarding conversations about clinical trials and experimental treatments? And I know in your book you talk about what happens when discoveries disappoint, treatments fail, and cures never arrive. Would you like to expand on that a little bit further?
So, these days, thank you for that question, Kathleen. There are so many hundreds and thousands of clinical trials here, everywhere. These days, people can enroll in trials interstate, they can go overseas. The world is full of clinical trials, and there are very good clinical trials. And the drugs we use today are based one day on the trials that happened with those drugs. So I think that there is benefit in enrolling in clinical trials that are carefully considered. So what does that mean? I think firstly, this requires sort of very plain language communication with the treating doctor about what to expect, which goes to which goes to a couple of sort of briefly mentioned things. So kind of what sorts of trials there are. Are there early phase trials where they have mainly been done in the lab and we are just getting into human trials? Are there later stage trials where they have proven effective in smaller populations and now we are doing bigger trials? Toxicity, time toxicity, how many scans, how many blood tests, how much presence is required, and what sort of results are people seeing? So one of the things I'm very conscious of is that a doctor's idea of something that is really good or something that is positive may not be so for the patient. And it's a very vague thing to use, a terminology to use to say, I reckon this is good. And people need to dig down a little bit deeper because my good is not the same as your good. And so it's very important to go into trials with your eyes open. And one thing I always say to all my patients, regardless of what kind of treatment they're having, you're not signing a lifelong contract to continue with something that doesn't suit you. So I think people should always feel empowered to say, pause, stop, let's revisit this. It doesn't seem like it is in my best interest.
Yeah, I think that speaks to too about the difference, information needs and how people use that information. And for some patients, it's really difficult to understand why they're not getting the same treatment as the guy in the bed next to them who's got the same disease. But there's so many other variables. From a doctor's perspective, would you like to make any other comment about why there's so many variations in care and even adjustments to different treatment protocols between people? Because it's not just about, what's on paper.
So I think, one way to quickly raise an oncologist's blood pressure is to say, well, my neighbor is having the same treatment.
Yeah, that's it. That's it.
So it happens every day in clinic. And I think increasingly, we know that all cancers are different. No two cancers are exactly the same, because even if they are the same pathology, they're happening to a different person.
Yeah.
So I think the idea of comparing treatments should be thrown out because it's actually really unhelpful for patients.
Yeah.
So it's just not a helpful conversation to have. I think, but it's very okay for patients to say, just curious to know that, I know someone with breast cancer is having tablet therapy, but you're suggesting that I should have intravenous therapy, because that's an opening to a conversation about why something is different for them. So I think just asking questions, being curious about your treatment, is really important. And I think Craig just wrote in the chat something that I think about a lot. You said, you know, do doctors realize how important it is for patients to trust them? I would say that it's not something that crosses most doctors' minds that a patient doesn't trust their expertise. And I'm not saying that's right, but I think that's what happens. People come in and you think that patients trust your expertise. But you make a really good point in that trust needs to be earned. And I hope that doctors sort of absorb that message that they're not owed trust, it needs to be earned.
Yeah, I think that inherent expectation we put on people is a difficult one to quantify, isn't it? I just wanted to pivot a little bit to something Eleanor talked about, which is the sticky conversations, the tricky ones where you have to revisit a conversation and perhaps have talk to your family about your illness. And perhaps you have a different perspective and you're wanting to know about prognosis because you're wanting to plan for your future and think about what that means for you and how you might change decisions or use your time. And yet your family are still sitting in the hopeful for cure camp. And how, as a doctor, you sort of weave those two stories together, or how you suggest people speak to their family, because it's a perennial problem, isn't it?
Yeah. Eleanor, did you have anything to say about that? I feel like you have so much lived experience to offer, and then I can go on.
I think that is such a complex area. We have actually had a very similar situation in the family where we've been exploring whether we stay on a drug trial or whether you go for a cure with a transplant, and understanding the complexity of, well, you're talking about that time toxicity. So you're talking about what the quality of life is going to look like with the transplant and what the quality of life is going to look like if we keep going on the road that we're on. And strangely enough, even though the transplant offers a potential cure, when you're looking at how you want your life to be, or and that time toxicity, it looks like staying on the trial would actually give you potentially not more time, but better quality of life. So you're looking at a number of different aspects, not just looking at whether or not there's a cure, but what kind of time that gives you and what the quality of that time is. But I understand Craig's point of view, how difficult it is to understand the detail in all of that. And I think that's because potentially sometimes the medical practitioners don't know, because each person is different. So they can't give you all that detail in the same way.
Thanks, Eleanor. And Jenny, your question was around how to bring the family if there are differing expectations around prognosis, etc. So look, I am a great believer in sort of simplicity and honesty. So when my patients are becoming unwell, I will often say to them, would you like me to have a chat with your family? You don't need to be present, and I'm quite sort of open about that. I think the same thing could be adopted by patients to say, if you are wanting to, firstly, assuming that the patient wants to have such conversations, I think to say to a doctor, to the nursing team, look, I think it's time we had a good conversation about where we are going, and I would like to have an open and honest conversation. I think that gives doctors permission to do things that sometimes they feel reluctant to do.
Yeah.
If the family wants to know and if the patient doesn't want to know, I suppose if it's an adult consenting patient, then we never have to speak to the family if that's what the adult wants. So I think this becomes more of an issue of how you handle this as a family and relatives. And I think a lot of sensitivity and care is required. From my experience, when I think about the people who have sort of done this alone or gone alone on this journey, often it is through good intention. And I think perhaps periodically saying to someone they don't have to be alone in this, that you care and you want to support them, etc., is important. I think as a society, we don't like to talk about mortality. So to normalize it and to say, you know, this is going to happen to all of us, every single one of us. And so it's okay to discuss things that are somber and sad. I think that can help break down these barriers. But yeah, it's tough when an adult doesn't want anybody else to be involved because they have the right to come to clinic alone and take the information they want and so on. But I do think that underneath it, there's a lot of fear, usually not arrogance or like a deliberate decision to put people out, but a lot of fear and a lot of love, actually.
I like that the love's come into it, because that's where that seed of emotions is, isn't it? Eleanor, did you want to comment at all about that? Because I know that you've worked on an advanced care directive with your dad, and that's invoked some pretty pointy questions. And I think when we spoke last week, you realised also it's not a one-off conversation. Is there something you want to add to that from that personal perspective?
I will, sorry, correct and say we haven't done an advanced care directive, but we've done the rest.
Thank you.
But I have done many advanced care directives with others, but not with the same kind of, I guess, poignant emotional background. Would you mind just repeating that just a little bit, just so I go to the heart of what you were asking me, because I really got a little bit stuck on the fact that I hadn't done an advanced care directive and didn't want to lie.
I threw you off the deep end there, didn't I? I think it's looking about when you have to have these conversations from a personal perspective. Yeah. And perhaps some people are looking to the future. You know, I'm cognizant of your mother practicing being on her own. So there's an inherent anticipation of a point where your dad will die. And it may not be from his blood cancer, it may be from something else. But I think Ranjana makes the point that death is the universal destiny. But if you've got a blood cancer, you might feel like it's zoomed up more in your face. So how your family has, I guess, navigated conversations around mortality when perhaps you weren't always on the same page at the same time.
I think that we have used an instrument of bluntness with each other. And I think, and while I do believe that diplomacy is really important in these situations, I actually equally think that being real and saying difficult things and talking about it and saying those things out loud is really, really helpful. And at points, I understand distressing, but also there is a release from saying something that is real and potentially true, but is hard. Yeah. So I think that is we have used bluntness and a little bit of humor to talk about some of those really hard things, and potentially, even though it's real, put it in a funny situation or scenario to discuss. But that's how we've done it. And it is actually an approach that I would use with my clients as well, you know, to say, all right, if this is to happen, I mean, I often use, even if we're not going to talk about that you're dying from blood cancer, I would use, well, what if you're hit by a bus, you know, and just something very blunt and forthright, just to say what is really happening, and then kind of pull it back from there.
Yeah.
I think I spoke about this at the last webinar we had, but I don't remember who told me, but when the family gets together for Christmas every year, there's this family that goes around the table and says, right, what would you like to do if, how would you like us to treat you at the end of life, or if you couldn't speak for yourself? Yeah. And it's a happy occasion, and they go around the table, literally, and they do this, and they're like, right, that's it, Merry Christmas, let's eat.
I kind of like that, but maybe that's a bit grim because of, you know, the what I practice in, where I'm constantly asking people what I want to talk about. But I think that'd be really helpful if everyone said that. There would be no confusion later on.
In our family, it's more like, when you die, can I have? We have.
Also an important one to have.
Yes, that's right. I think it leads to a really good question. You know, I think the only way out of this life is by dying, and we pretend that it's not going to happen. And I think what the blood cancer does, it puts it right in front of your face again. And a lot of people ask us, how do we plan if we don't know what the future holds? And in some ways, we kind of do know what's going to hold, and in other ways we don't. So Ranjana, how do we plan if we don't know what the future holds? And what role does perhaps palliative care have in planning for the future?
I think Eleanor makes a really good point. The future holds a decline in our health and well-being and dying for all of us. Just how and when. So perhaps a helpful way of looking at this is, well, what would I want anyway if I didn't have this illness, and try to plan ahead. So for instance, I'm doing my advanced care directive in a couple of weeks while I'm well. So I think there is something to be said for just sort of taking the bull by its horns and saying, well, these are things that are important to me. And regardless of what illness I have, these are things that matter to me. And I accept the point that when you have been diagnosed with an illness which doesn't have a cure, or which is difficult to cure, all of that immediacy is confronting. But I think it's a helpful way to look at, well, these things need to happen anyway. Where would I want, how would I want to spend my, whatever, what would I want to give to people? Who would I want to spend time with, and so on. And then enact it like that. I think that for that to happen when you have an illness, and if you are the sort who will only do something if you think that it is important to do now, then you need to have that conversation with your clinician to say, I have important things that I would like to do, and hence, I would like to know some details about my illness. So I wrote another column in The Guardian several years ago about these patients who come in and say, doctor, can I go on a cruise? And then I say, well, when is the cruise? And they say, well, it's August now, it's next Christmas, as in Christmas the following year. And I think it's a way of saying, will I be alive in December 2025? Yes. Or, in December 2024 for that matter. And so that's sort of a roundabout way. So say it's August, September now, and they say, can I go on a cruise in December this year? So I might say, okay, well, that's 3 months away. They're not going to clearly ask me about how long do I have to live, but that's really the question they're asking, how will I be? So then I feel quite comfortable having a conversation that says, well, you may be well, but chances are that given the extent of your illness, things might change and you may not feel as well. So if this cruise is really important to you, then maybe try to go earlier.
Yeah.
Or, they'll say, well, the whole family is going to come on this cruise. So it's like, well, then it's something you would really want to enjoy in your element rather than feel sick half the time. So is there a way of bringing that forward? Same goes for weddings. I have these conversations about weddings, someone is going to get married. Do you think I will be well enough next February? And I'm like, well, I hope I can keep you well, but perhaps not. So perhaps you want to have a conversation with your son or your daughter about what else can we do if I'm not well. So it's surprising what happens when you are able to be a little bit honest and vulnerable and open about these things that are important.
It sounds to me that in all of this, the theme is being brave, speaking up, and actually saying the things that are on your mind, even though it's difficult, because at the end of it, there's better outcomes for everybody, really. Ranjana, I know that you have a particular passion for working with people from disadvantaged communities, people for whom English is a second language. And I'm thinking of people now who may be disadvantaged by our healthcare system, and they are people who don't speak English, First Nations people perhaps who identify as LGBTQIA, whose specific needs we don't recognise, people that live in remote areas. How can they advocate for themselves strongly, given their circumstances and given that not all clinicians will be aware of their specific needs?
Yeah. That's a big question. Firstly, just to answer Sarah's question around a rare cancer.
Sorry.
So rare cancers can be quite difficult to manage sometimes and to get information about, but fortunately, we do have an organization called Rare Cancer Australia. So I would recommend that you look them up and approach them for some advice about your particular situation. To go on to, now I have forgotten your question, Jenny. Yes, about disadvantaged community.
Groups.
Unfortunately, I wish there is no pat answer to that question. I think that this is a genuinely difficult topic, and time again, I see that despite good intentions, how poorly these patients are served by the healthcare system, which really requires a degree of sophistication that most people don't have. I think as much as possible, if you are a patient or a relative or a friend of somebody like that, connect them to the right resources, and they're often not doctors. So for instance, when I see an Indigenous patient, I am very quick to find a liaison officer, because an Aboriginal liaison officer is then able to at least speak the same language, the broad language, and understand things that may not be apparent to me. And they're often like the socioeconomic determinants of health. It's all very well to prescribe, high-end, sophisticated treatment to someone, but if they don't get to the treatment in the first place, or if they don't trust you, then it's wasted. And that happens a lot. For people who are migrants, refugees, asylum seekers, there are various health services, refugee health services, migrant health services, same language things. In Victoria, the Cancer Council of Victoria does a very good job, for instance. I'm sure there are others, but I think one thing I would say is not to accept simply that because you are different, your needs cannot be met, but it does take more advocacy. And perhaps, the patients who I have seen thrive are often someone who has a friend in the system, and that friend is usually a nurse.
Yeah.
And they're not a social friend, but has found a friend within the system.
It tells me we need to think more broadly about, when we talk about treatment team, need to think really broadly. It's not just your doctor and your GP, isn't it? It's the pastoral care worker, the social worker. It's often the cleaner that speaks the same language as you. It might be the physiotherapist, it might be the clinical nurse consultant. It's whoever you can find that you can, I guess, feel that you have a shared understanding, and that person can help you in some way to find your way through what can often be an unfriendly system.
And one way of locating such people is, if you are traveling in for treatment, ask the nurses, ask the infusion center, people like that who are able to connect you, who are in the know.
Yeah. I had a great time reading your most recent book, A Better Death, and there was a fantastic question in there that I want to ask you to talk about, because I think it really speaks to people's fears, and that is, does foregoing treatment equate to giving up?
Such a loaded and such an emotional question.
Yes.
So my short answer is no. I mean, with all the experience and with all the patients that I've had, in fact, this happened just this week. We were talking about a patient who is very much at the end of life, who's young and who has children. And this discussion was on paper. The patient wasn't there, and various people, and she was slated to go to hospice, so inpatient hospice, which means she was really at the end of life. And then someone brought up in the meeting a new treatment and said, to the treating doctor, do you want to try this? And you could see the expression on the treating doctor going, oh, I hadn't thought about that. And so I sort of said at the meeting, just because a treatment is available doesn't mean it is right for that patient. And you have to use your clinical judgment sometimes, even broaching something with a patient who is hospice bound. And it was a very difficult situation. So this is just to paint to you the dilemma that doctors face, because there is always some other treatment that you can offer someone. The question is whether it's right for them.
Yes.
So this is one of the most vexed conversations in medicine I find, because I think it is human to have hope.
Yes.
And it's human to say, well, maybe I should just try something else and maybe it will work. But I think that there is a lot of wisdom in reflecting, in saying, well, especially, and I'm now talking about sort of last ditch treatments, when you have broken through several treatments, to say, well, what's important to me? More treatment. And it could be that that's the way you want to live and die, and that's okay. And there are people who will say to me, I just need to know that this is what I did, that I went through this operation, even though you're telling me this operation is high risk, or I need to know. And unfortunately, every year we have people who die sort of just after having had chemotherapy. It's tragic and it shouldn't happen. But I think this is where sometimes patient autonomy takes us, and we need to accept. But for a lot of people, I feel they're just not aware. They're just not aware that treatment may be futile, that treatment doesn't have a lot to offer. And I think in these instances, it's really important to offer numbers, clinical judgment, rather than do you want to have this treatment, which is a very difficult thing to say, well, no, thanks, I don't. And I keep telling my residents and the people I train that, toxic treatments are not like a buffet option. It's not a supermarket aisle. Will you have this or will you have that? They are very strongly considered decisions. And if you are at the point where you are considering foregoing treatment, to me, it suggests you have been very unwell, and you are very unwell. Time is often limited, and you need to take stock of what matters to you. And on a very interesting note, and I listen to this, and each time it sort of grabs me, there's been quite a bit of research around the fact that the treatments that doctors prescribe to their patients, they would not accept for the same level of benefit. So that says something about our treatments. It's a really, it's something that's a very, and it's not because doctors do it in bad faith, but I think when it comes to considering those treatments for themselves, they're so aware of time toxicity, of general toxicity, that they say it's not worth it. And it's something I always try to remember, would I have this treatment? But then the flip side of that is that patient is not me, so I can't transplant my judgment onto them.
Yeah, it is a really complex and vexed question. And I guess, some doctors are very reluctant to talk about prognosis and time. And it's quite a complex thing because there's so much tied up in that. But that, I'm curious about that idea that they wouldn't have a lot of the treatments that they're suggesting. What's the question in this? I'm wondering if you've got some insights into some of that complexity about setting a prognosis or discussing that treatment or to stop treatment, and why that is so difficult to both have and for patients to understand.
Prognosis is something that weighs a lot on my mind, because I think that without knowing prognosis, it's difficult to make decisions. So here is sort of the professional's view of prognosis. Doctors don't like giving a prognosis because they are often wrong. And they feel that it's a, it's a disservice. And, there are studies that say you can sort of toss a coin, and doctors can be right half the time, wrong half the time. But I think prognosis is more than how many months somebody has to live. I think the average person thinks prognosis is a number. I think prognosis is a conversation.
Okay.
So whilst I can't say to someone, whether they have 3 months or 6 months or 10 years, what I can say is based on experience, based on research. This is good prognosis, this is average prognosis, this is poorer prognosis, because that's what we do day in and day out, firstly. So I think clinical judgment is important. To say to people that no matter what stage of their journey they're in, quality of life matters, and what does quality mean to them? You know, and I see a lot of patients who feel very poorly and their disease is doing okay, but they're really sort of not well from their treatment. I saw somebody like that this week. And so the question was, well, the treatment is keeping my disease stable, but it's making me feel crap. What do I do?
Yeah.
And I think there is a lot of that. So how do you balance that? How do you give people treatment breaks? Do you reduce the dosing? They're very individual conversations to have with patients about what it is that we can do, but absolutely it's a conversation. And I also think that one of the things I say to my patients about prognosis is if they look back at the last 3 months and how they're feeling, the next 3 months are probably a reasonable prediction of how they will feel. And patients are like, 2 months ago, I was fine, and look at me now. And I'm thinking, well, it may be very difficult to get you back up to that level. So I think people can gauge. I guess the message, you know, it's a complicated question, but the message I want to send to people is that prognosis is not something that is completely within a doctor's grasp and not your own. I think we all know how we are feeling, our own, how we are responding to treatment in terms of reacting broadly to treatment and what is important to us. And I think to give all that control to a medical professional is not right.
Yeah. And it goes back to something that you said earlier that's been mentioned about having honest communications with yourself. Because I think most of us know when things aren't going well, but we kind of don't want to know that they're not going well. So, yeah. Eleanor, I wanted to bring you in on this because, you know, we're talking about difficult decisions and perhaps advanced disease and end of care and end of life care, but from a practical and legal perspective, let's go to your legal brain. What sort of, is there a difference between an advanced health directive or an advanced care directive, or what sort of things do you think people need to consider when they're completing one of these?
So firstly, the advanced care directive is, I think, the general term that we use in Victoria. And then an advanced health directive is normally, I think that might be Canberra or New South Wales. I don't practice in those areas specifically, but in that jurisdiction. But I believe that's just a difference in terminology, and why there might be a few differences in the documents. I think the point of them is the same, so they serve the same purpose. And just going to your next part of the question, I think when you're wondering what you should consider when doing an advanced care direction, I think you have to have a think about the purpose of why you're doing an advanced care directive and what the purpose of that document is. So I know Ranjana had said that she was currently looking at doing one herself, and while you can do one as when you're in perfect health, people are more likely to consider doing an advanced care directive when you have a diagnosis of a serious disease. And the purpose of them is really to give information. So there's 2 parts, particularly to the one in Victoria. So there's 2 parts to your advanced care directive. There's a statement of your wishes, or a values statement, and then there's a directive. And both those parts have, I guess, a different purpose. So your value statement is really giving information to a medical treatment decision maker, so someone you appoint to make decisions on your behalf if you've lost capacity, or a doctor or a medical practitioner, about where you lie on quality of life, what quality of life means to you, what values you have around palliative care and your death and dying. Whereas the directive part is, if you've lost capacity to make decisions for yourself, it's really almost an instruction to the doctor that they must do something.
Right.
And I think that that's really important. So I would if you have some really specific ideas, such as you don't want to be resuscitated, or you don't want to be kept unofficially alive, say through a stomach tube if you've lost consciousness or in a coma, those are the kinds of things that you would put in a directive. And you might also put in there something if you have certain religious values around, I don't know, blood transfusions or anything else that's really important to you for religious and cultural reasons, you would put that in the directive as well as mentioning it in the statement of values part. So it's really serving a purpose to kind of inform people of your values and your personal wishes, and also giving instructions to a doctor.
So they're quite separate, but very strongly linked aspects.
That's right, and in the same document. So if you've appointed a medical treatment decision maker, or if you haven't, that value statement really helps your family and friends know what your wishes are if you've lost capacity to make those decisions yourself.
Thank you. And I think that goes to a point that Ranjana made very early on about someone who had died and their family had no idea of what their thoughts were. And that includes what you want for your wishes medically, not just after you've died. I wondered too, Eleanor, finally, around this topic, how often you think that needs to be reviewed? Because often we do it when we're in good health. We can't imagine being sick, and then we get sick and think, oh no, actually I wouldn't want them to withdraw this or not do that, or vice versa. Do you have any suggestions around how people can navigate that?
So I think firstly, I would generally recommend that you wouldn't complete the directive part if you're in good health.
Okay.
Because I think that the directive part, if you lose capacity and say your directive is 15, 20 years old, there could be medical advancements that you haven't considered that you would actually agree to, but you've said no treatment, or you've said you've given really specific circumstances. So the directive can be hard because you want to ensure that you have that you can change it and that you have capacity to do so. So I would normally encourage someone to do that if they have a terminal illness or some kind of other serious health concern. But in relation to doing it when you're healthy, the value statement, I think that, and reviewing that, I think that's something that you can do regularly as long as you have capacity to do so. And I certainly, if your values change about how you want treatment to be for yourself, or how you view yourself if you've lost capacity and how you want to be cared for, then I would be updating that as you go. And the tricky part of that is you have to see your doctor to have it signed off each time. So, it's something that can be easily done if you're seeing your medical practitioner, and you can do it yourself, and then or with a lawyer or with a medical practitioner, but you have to sign it in front of a medical practitioner too. So I think that's part of the tricky thing. But it's something you should be reviewing once you've done once, then you should be looking at it at least 3 to 5 years, unless you had some kind of life event, which means you should look at it sooner.
Yeah. Thank you. Ranjana, did you want to add to that in any way before we ask our final question?
I thought that was a very comprehensive answer. Lots of good food for thought.
Thanks, Ranjana.
Yeah, thank you. I'm conscious, Ranjana, that you spend a lot of time in your latest book talking about your personal and professional encounters with death and dying. And I wondered if, to close this out, because, there is only one way off this planet, if you'd like to perhaps make some comment about what you've learnt about death and dying, or what makes a good death.
Yeah, that's I do deal with a lot of death and dying, and that's a big question. Look, I think when I see people after their loved one has died, so firstly, I think the common themes that I hear about people who are dying, many people are actually not afraid of death, but of the pain and suffering that they expect to have. So I think that's a clear one to try, especially in a country like ours, where we do have access to palliative care, which most of the world doesn't, in fact. I think to allay some of those fears and to embrace palliative care early is a good idea. And embracing palliative care doesn't mean you're not having treatment, but they're side by side. So I think that's one really important thing for the patient. From a family's perspective, I think when I talk to people who have lost somebody, the things that they count as a good death is having had support, both from doctors and nurses and treating teams, as well as family and friends. So I think as just human beings, we shouldn't underestimate the value of supporting each other and supporting those we know through really difficult times by checking in. In fact, my next column is about this issue about grieving and bereavement. It'll be out next week. I think people look back and often, even when I have lost people who are young, who really should have lived longer, what the family remembers is the quality of the dying and the quality of their life. So while people will often say to me, I don't know how I will cope when someone dies, this is a very common conversation, people are incredibly resilient. And this goes to Eleanor's point about your mom saying, very, very poignant. But what I see is people are incredibly resilient about dealing with the situation that they are put in. So I think, as a doctor, when I think about helping people die well, and importantly, helping the people who are left behind cope with that, I think ensuring that people have access to honest conversations, palliative care. Perhaps something very personal to me is thanking patients for the privilege of being involved in their lives. I think sometimes I don't know from one point to another whether I'll see a patient again in my clinic. And so to treat that as a real privilege to be in their lives is important. And to mention that, I think that means a lot to patients and to teams. And then not forgetting the people who are left behind and checking in on them and learning from each experience to make the next one better, I guess.
Thank you so much. It's been a wonderful discussion, and I'm sure we could keep going for another hour, but I'm going to hand back to Linda at this point in time.
Thank you so much, Ranjana and Eleanor, for a very thoughtful and thought-provoking and really delicate conversation. We've covered such an array of topics, but with that critical element of the essential element of the communication and the relationship. I think that's what's really been highlighted today. And the importance of staying true to your deepest convictions. To finish up, Ranjana, I'd actually like to quote you from our webinar from last year, because I think it links really beautifully in with our topic today. One way to shift the dial in healthcare is to democratise information for everyone to have access to good information, good knowledge, and to thrive. And I think that's right. With good information and good knowledge, that does put people in the driver's seat to have agency over their own lives. We'd like to thank the audience who have joined us today. We encourage you to use what you've heard today to start conversations with your doctors and your treating teams and your family and friends to help you get the information that you need, and ultimately the care that aligns with your own personal values and preferences to enable you to live well and to plan for your future. A few final reminders that if you do need any further information, to please check out our resources on our website, on the Leukemia Foundation website, or to give us a call on 1800 620 420. And for more information about Blood Cancer Awareness Month, please go to bloodcancer.org.au. A couple of just very little things before we sign off. A short survey will be emailed to you. We do really appreciate all feedback because it helps us design education and information that you need So please let us know how you found today. A recording of the webinar will be sent to all registered participants and will be available on our website and YouTube channel in the next 24 hours. That draws our webinar to a close. Thank you once again. Go safely, and until next time, bye.